Good morning. I'm Dr. Timothy Murray. I'm the director of the Ocular Oncology Service at the Bascom-Palmer Eye Institute. I'm a professor in ophthalmology and radiation oncology at the University of Miami Miller School of Medicine. I had the pleasure to be the invited speaker for the Pan American Research Day for 2012 at this year's ARVO, and I'm going to share the content of that presentation with you with a focus on ocular oncology and a particular insight into the management of children with intraocular retinoblastoma. For this talk, I have no financial disclosures, but I will be discussing the off-label use of both drugs and devices and potential off-label use of surgical procedures. Retinoblastoma is the most common primary intraocular malignancy in childhood. It affects between 1 in 12,000 and 1 in 15,000 children. Current treatments for this disease began with enucleation surgery, shifted to systemic chemotherapy, included external beam radiation therapy, and have moved toward focal therapies with an attempt to save the child's life, retain the eye, and preserve vision. Unfortunately, even today, advanced retinoblastoma tumors are common at presentation, and advanced tumors are the most difficult to control, with failure rates that range from the Bascom-Palmer Eye Institute failure rate of approximately 20% up to failure rates of 80% around the United States. Failure is almost universally associated with advanced disease and either vitreous seeding or subretinal seeding. The presenting signs are important for us to recognize immediately, and from an ophthalmologist perspective, these signs are very standard. Approximately 60% of children present with leukocoria, the classic cat's eye pupil. About 20% of children, 1 in 5, will have a secondary strabismus, and less than 10% of children will present with a red painful eye. It's important to recognize that this diagnosis is often delayed, and it's seen rarely on a well baby examination in less than 3% of the children. As you can see here, some excellent clinical examples of presenting leukocoria. In the slide to your upper left, this child's left eye has classic leukocoria with the white cat's eye pupil. In the slide to your lower right, you'll see here that the left eye has a complex leukocoric presentation, but also complex secondary strabismus with the left esotropia. On your left, you see the Christmas photograph of the child that presented to us at Bascom-Palmer. His family wasn't concerned about the leukocoria you see in his right eye because their dog Brutus had leukocoria in the left eye. Unfortunately, Brutus's leukocoria, the dog's, was secondary to a traumatic cataract, while the child's leukocoria in the right eye was from complex advanced retinoblastoma. As you might expect, this led to a significant delay in the evaluation and diagnosis of this child. I'd like to give you some clinical examples of retinoblastoma today to show you what this looks like in presentation from very early small tumors to very advanced large tumors. There are 2 staging classifications for retinoblastoma. The classic is the Rees-Ellsworth classification, which evaluated tumors based on their clinical presentation and their expected response to external beam radiation therapy. With the shift from external beam radiation therapy to systemic chemotherapy, we instituted a new classification scheme, the ICR classification, or the International Classification of Retinoblastoma. Early tumors in Rees-Ellsworth are typically stage 1 through 4, and in the ICR classification are stages A, B, or C. Tumors show a translucent white-gray fleshy mass within the retina. There are dilated intratumoral retinal and tumor vessels, and there may be microcalcification. You see the low magnification and high magnification of this child who presented with a right macular retinoblastoma, the classic microcalcification, the small white areas within the tumor. You see the dilated vessels within the tumor and in the surface overlying retina, and you see the salmon fleshy appearance of the intraretinal tumor. Here's classic leukocoria in the left eye, and on the fundus examination here with indirect ophthalmoscopy, you see a large macular tumor focal dot blot hemorrhages within the retina, and a secondary exudative retinal detachment. More importantly, within this child, when we evaluated the left eye with obvious retinoblastoma, we were also able to detect and then institute treatment for a very small early juxtafoveal retinoblastoma in the right eye. And you see how subtle that tumor is in the right eye. Very little elevation of the retina, small microcalcification, and dilated retinal vasculature. Unfortunately, most children with retinoblastoma present with advanced disease. Typically, RECELLs were at stage 5A or 5B, or the ICR classification D or E. This is associated with a large tumor mass with either vitreous or subretinal seeding. These tumors are typically non-cohesive, which leads to the tumor shedding into the subretinal space or the vitreous. It may be associated with an advanced presentation that includes rubeosis iridis or iris neovascularization, and even secondary neovascular glaucoma. Tumor necrosis is often seen with these late presentations and may be associated with periocular inflammation. Here on the upper right, you see the small fluffy granules of vitreous seeding from the primary retinoblastoma tumor, and in your lower left, the leukocoria, but with close evaluation, you can see that this represents seeding of the vitreous cavity independent of the primary tumor. There have been significant advances in the management of retinoblastoma over the 2 decades that I have been at Bascom Palmer. In the early 1980s, 85% of children that presented with retinoblastoma had their eye removed or enucleated. By 1991, 85% of children with retinoblastoma were now treated with external beam radiation therapy, and the enucleation rate had decreased to 25%. By 2001, a decade later, 85% of children with retinoblastoma were treated with systemic chemotherapy, and only 10% of the eyes are enucleated. And now, in 2011-2012, 90% of children at the Bascom Palmer Eye Institute are treated with focal chemotherapy, typically either intra-arterial chemotherapy or periocular chemotherapy, and we enucleate less than 5% of the eyes. A remarkable shift over a 2-decade period. It's important also to recognize in the ocular oncology field that our focus differs from that of our general ophthalmologic colleagues. In this case, we're interested in, number one, having the child survive this tumor that may lead to death. And in fact, in our great-grandparents' era, almost 100% of children with retinoblastoma died from their disease. Now that we're focused on survival, we've shifted to globe conservation therapies where we're interested in preserving the eye, but not just preserving the eye with functional vision and improved visual outcomes. At Bascom Palmer, we've also had a significant interest in decreasing the treatment-related morbidity. So keep the child alive, save the eye, keep the vision, and lower the complications related with treatment. So I'd like to talk to you about some of the controversies in the management of retinoblastoma. The biggest controversy continues to be how to manage advanced retinoblastoma disease. Typically, RECELLs were stage 5B or the ICD classifications D and E. We still do not understand in its entirety the mechanism of tumorigenesis with retinoblastoma, and we have been very interested in developing novel alternative strategies that potentially eliminate the need for chemotherapy, improve local tumor control, and decrease tumor-related morbidity. The first study I'd like to discuss is a single institution IRB approved study from the Bascom Palmer Eye Institute Ocular Oncology Service between 1996 and 2002, evaluating children presenting with pediatric retinoblastoma. We had 2 subsets of this series: early advanced disease, which was RECELLs were stage 1 through 4, and late advanced disease, which was stage 5A and 5B. The early tumors corresponded to the ICR classifications A through C. We had a standard chemotherapeutic protocol which was unique at that time, and that chemotherapeutic protocol remained standardized over a 1.5 decade period. We utilized carboplatin, vincristine, and etoposide with intravenous delivery. We used 6 to 9 cycles of chemotherapy delivered every 3 to 4 weeks. And uniquely, we applied focal laser ablation to the retinal tumors on every examination under anesthesia preceding every systemic chemotherapy delivery. We used a complex custom large spot size diode laser, and all the children that were evaluated with examination under anesthesia underwent intraoperative imaging, including RETCAM wide field imaging, high resolution ultrasound, and recently spectral domain OCT. This study evaluated 149 eyes in 119 children, 66 girls and 53 boys. The youngest child that was treated was 3 days old, and the oldest child that was treated was 66 months old, with a mean presenting age of 14.1 months. This is a classic case presentation from that series. This is an 11-month-old boy who presented with history of leukocoria over 1 month. He had central steady unmaintained vision in the right eye and central steady maintained vision in the left eye. The right eye had a Reed-Sellsworth stage 3 or ICR stage C tumor. This was unilateral and unifocal at presentation. Here you see that the tumor virtually obscures the optic nerve, involves the entire macular region, and has focal luteal pigment. There's both an exo and endophytic component of this tumor, and there is a complex retinal detachment. This child was treated with 9 cycles of 3-drug chemotherapy utilizing the carboplatin, vincristine, and etoposide, and was treated with each cycle spaced every 3 to 4 weeks. There was an examination under anesthesia before every cycle of treatment, and we applied large spot size diode laser treatment at each examination under anesthesia. Uniquely, 4 months after the last cycle of chemotherapy, this child developed an independent small retinoblastoma tumor in this eye, classically consistent with an RB1 mutational alteration. We were able to follow this child now for 10 years from treatment, and remarkably, that eye with the large primary tumor in the right eye involving the entire macular region is 20/50, while the left eye is 20/20. This is the photograph 1 month after institution of chemotherapy, and you'll see a marked 70% reduction in tumor volume and a significant decrease in the exudative retinal detachment. We now clearly see the optic nerve, and we see a marked decrease in the luteal pigment. This is the intensity of laser that was applied at that second session of chemotherapy using a large spot size diode laser and treating till we see translucent changes within the retina or whitening of the primary tumor. This is the child now 10 years after last treatment. The eye is 20/50. The tumor has been stable. Far temporally, you see a small independent scar from the independent retinoblastoma associated with the RB1 mutation. This child has done remarkably well. We had a mean follow-up of 82 months. 119 of 119 children were alive and well, as you should expect with retinoblastoma, a survival rate approaching 100%. Remarkably, in these 149 eyes, we did not require enucleation in any eye. We did not require external beam or plaque radiotherapy in any eye. New tumors developed in 27 of the 149 eyes that were treated, as we now know to expect, approximately 20%. And the mean visual acuity for this series was 20/40, with the range from 20/20 to 5/200. At that same time, we looked at the advanced retinoblastoma series, Reed-Sellsworth stage 5A and 5B, and the ICR classification C/D. We expected to have a lower tumor control rate, and in fact, that's what we saw. Nonetheless, the tumor control rate here approached 80%, which was remarkable. There was an increase in the second independent tumor development from approximately 18% to 38%, as we also know to expect. But more importantly, almost 50% of these children had chemotherapy-related toxicities. The most common toxicity in these children was myelosuppression, leading to an associated fever of unknown origin that required hospitalization and aggressive antibiotic therapy. In this series, when children's eyes failed to respond to systemic chemotherapy, in all cases, that failure was related to progression of vitreous or subretinal seeding. In no case did the primary retinal component of the tumor fail. So it's important to recognize that failure for advanced eyes with retinoblastoma is related to seeding either in the vitreous cavity or in the subretinal space. So the clinical conclusions from this introduction are that we should expect a virtual 100% survival for children that present with intraocular retinoblastoma, regardless of an advanced staging. We've had a shift from enucleation therapy to external beam radiation therapy, from external beam radiation therapy because of second malignancy risk to systemic chemotherapy, and as we'll talk, a shift from systemic chemotherapy to focal chemotherapies. And with this, we've been able to retain the globes with functional vision and have seen a shift in enucleation rates from 85% as a primary therapy in 1981 to less than 5% in 2012. Unfortunately, aggressive systemic chemotherapy with a systemic delivery platform is associated with significant treatment-related toxicity, including myelosuppression in virtually 50% of treated children. And clinical failure is limited to seeding of the vitreous and subretinal space. I'd now like to shift the focus from treating children with retinoblastoma in a historical perspective to some of the advances that we're evaluating in the laboratories within the Ocular Oncology Service at Bascom Palmer. Our focus has been to improve treatments of retinoblastoma for children with this disease, to use animal models, particularly a transgenic mouse model, to explore novel therapies, and to focus on targets within the unique retinoblastoma ocular tumor microenvironment to improve strategies for new treatments. To evaluate these treatments, we've had several hypotheses that we've tested. First, we've hypothesized that retinoblastoma tumors late in the disease have significant intratumoral hypoxia. They don't receive enough of an oxygen supply to support the tumor. We also hypothesized that if we could eliminate the intratumoral component of hypoxia, we would have the potential to decrease the tumor burden and increase the response to both chemotherapy and, if necessary, radiotherapy. The novel target that we utilized and the drug compound that we explored was 2-deoxy-D-glucose. This is an inhibitor of glycolysis. It induces hypoxic cell death within 24 hours of treatment, and it works by blocking glycolysis through a binding to and suppressing of hexokinase, which is an enzyme that catalyzes initial metabolism in glycolysis. To evaluate this effect of this novel drug, we utilized the mouse model of retinoblastoma, which is an LH-beta T antigen model. We treated at 2 time points. We treated when animals had moderate disease, which was at 12 weeks of age, and when they had advanced disease, which was at 16 weeks of age. We utilized a large series of animals in each group, and we combined therapies evaluating standard carboplatin chemotherapy, combining that with 2DG, the 2-deoxy-D-glucose, and evaluating each independently. We have first evaluated the impact on hypoxia by analyzing these eyes 1 day and 1 week after treatment. We utilized pimonidazole, which is a staining agent that binds thiol groups in areas of hypoxic cellular activity. And in these series of studies, you see on your left the saline control showing approximately 50% immunofluorescence or hypoxic staining. And you can see that very nicely with the green hyperfluorescence on immunofluorescence. You see that carboplatin chemotherapy has very little effect on intratumoral hypoxia, but the use of 2-deoxy-D-glucose decreased hypoxia by over 90%, And the combination of 2-deoxy-D-glucose with carboplatin chemotherapy eliminated hypoxia in these tumors. Now, that's an important proof of principle, but as a clinician, we're interested not in the effect on the tumor, but whether we can decrease the tumor burden or eradicate the tumor. And this series of graphics document the tumor response to treatment with saline control, carboplatin, 2-deoxy-D-glucose, and the combination of 2-deoxy-D-glucose and carboplatin. And you'll see in the graphic that there is no tumor response to saline alone, that 2-DG and carboplatin both decrease the tumor burden but don't eliminate tumor burden. And this was the first documentation that the use of a non-chemotherapeutic agent, in this case 2-deoxy-D-glucose, could decrease and potentially eliminate tumor burden. But ultimately, the combination of carboplatin chemotherapy and 2-deoxy-D-glucose eliminated tumor burden in this animal model. So our results suggest that the LH-beta T antigen tumors do exhibit hypoxia, particularly late in the disease with an advanced tumor presentation. We have shown that 2-deoxy-D-glucose has the ability to moderate and decrease tumor burden as a single agent treatment strategy. We've shown that the use of 2-deoxy-D-glucose as an adjuvant to carboplatin chemotherapy virtually eliminates tumor burden in this animal model with a p-value that was significantly less than 0.05, and that remarkably 2-deoxy-D-glucose virtually eliminates intratumoral hypoxia and does eliminate intratumoral hypoxia when combined with carboplatin chemotherapy. This suggests to us that vessel targeting therapy and hypoxia modulation may be important clinical targets. It also documents how important vascular heterogeneity is as a tumor microenvironment marker for retinoblastoma, particularly in advanced intraocular disease. It suggests that animal modeling studies are critical to evaluation of novel treatments, and that these animal studies very closely correlate with the human children that are managed with retinoblastoma, and that glycolytic inhibitors such as 2-deoxy-D-glucose may have the potential to enhance current therapies for retinoblastoma and also may be associated with reductions in treatment morbidity. So what about these novel strategies? I'm going to talk about novel clinical strategies in the management of pediatric retinoblastoma in 2012. We evaluated first salvage therapies, which were utilized in children that were treated with aggressive standard protocols of treatment but failed, and their eyes were destined to be enucleated, and we utilized an alternative approach to avoid enucleation in these children. There have been two predominant therapies that we have evaluated that have moved from our laboratory into clinical practice. First is the use of periocular chemotherapy, and second is the use of intra-arterial chemotherapy, as was pioneered by the group in Japan and brought to the United States with significant modifications by David Abramson and Dr. Pierre Gobin. We're going to talk about the use of these moving from salvage treatments to primary treatments and what the role of these therapies are today. And the best illustration for that is this clinical example. This is a 7-year-old Greek girl who presents with us late with unilateral, multifocal, advanced stage 5B retinoblastoma. She has an ICD classification of C/D. She had no family history, and the treatment options historically would have been limited. Historically, that eye would have been enucleated, and we would have focused on preservation of her second eye. But it was a difficult decision for us because her vision when we saw her was 20/25 in the right eye and 20/20 minus in the left eye. And the examination was remarkably normal when we evaluated the direct fundus examination. One of the points we make in evaluating children with retinoblastoma is you can't limit your examination to the disc and the macula. You must examine all of the retina. So in these pictures of the right and left eye, these eyes look remarkably healthy. But in this same right eye, when we look out nasally toward the periphery, we see a large primary intraocular mass, classic chalky white presentation, a combined endophytic and exophytic detachment, secondary retinal detachment, and vitreous seeding. What you can't see in the photograph is an independent anterior tumor that is just posterior to the ora serrata at 12 o'clock. The left eye was uninvolved. So remember, the options for this 7-year-old child with 20/20 vision 2 decades ago would have been enucleation. The option for this child a decade ago would have been external beam radiation therapy. The option for this child several years ago would have been systemic chemotherapy, but this child was treated uniquely with a focal approach to chemotherapy. And we're going to talk about those focal approaches. So there are non-systemic chemotherapeutic managements in retinoblastoma that utilize either novel ways to deliver chemotherapy or utilize non-chemotherapeutic agents. The first that we've explored is the use of a non-systemic delivery by injecting drug around the involved eye using a periocular delivery strategy. And we have focused initially on the use of carboplatin. Many centers have now migrated to the use of periocular topotecan. There are now implantable gels and depot delivery systems that allow sustained release of periocular drug delivery with carboplatin chemotherapy, utilizing either gel, polymer, or miniature catheters. Periocular delivery of carboplatin chemotherapy is unique in that it utilizes 1/10 of the systemic dose of carboplatin chemotherapy, but it delivers a 10-fold increase in concentration to the vital structures within the eye. Periocular carboplatin chemotherapy is now in investigation within the Children's Oncology Group in a multicenter clinical trial combined with systemic chemotherapy in advanced retinoblastoma eyes. This is the first case report from Leng et al. That shows the use of periocular carboplatin chemotherapy alone without the use of any systemic chemotherapy to control tumor in this child that presented at 6 months of age with unilateral multifocal disease, showed progression in spite of laser chemotherapy. In the lower left, you see the ultrasound documenting the delivery of the carboplatin chemotherapy drug adjacent to the sclera and next to the tumor. And here on your lower left, showing this eye now 20/20 with 5-year follow-up in a child that never received systemic chemotherapy for treatment of the retinoblastoma. Though that treatment strategy has been important, the most novel transition is the use of intraarterial infusion of chemotherapy, a treatment strategy that was pioneered and initiated in Japan and has now been widely disseminated both internationally and nationally in the United States. We utilized this treatment approach initially as a salvage therapy on eyes that were destined for enucleation that had failed standard chemotherapy management, and we've now migrated this therapy to a primary treatment for both presenting early and advanced retinoblastoma. The drugs used here are uniquely different from those used in systemic chemotherapy, and the most significant evaluation of drug use for intraarterial chemotherapy has been Malphalon chemotherapy. We now use Malphalon in combination with either topotecan or carboplatin as a multi-drug treatment strategy. This is a graphic from Dr. Abramson's presentation in April 2010 in the journal Ophthalmology, and it shows the use of intra-arterial supra-selected ophthalmic artery canalization and delivery of Malphalon chemotherapy. This treatment requires children to be placed under general anesthesia. It requires anticoagulation for cannulation. We approach the eye through a femoral artery, and then we directly cannulate the ostium of the ophthalmic artery with a microcannula. Again, this was initially investigated by the use of intracarotid chemotherapy delivery by Kaneko and colleagues, and then modified by Abramson. We utilize angiography to look for vascular variants in these children. but typically we can cannulate the ophthalmic artery and deliver drug to the ophthalmic artery in almost 100% of the children that we've evaluated. This is Yamena and Kaneko's first approach, where they did not directly cannulate the ophthalmic artery, but they balloon occluded the internal carotid artery and let the chemotherapeutic agent backflush into the ophthalmic artery. At Bascom Palmer Eye Institute, I was not interested in the use of this approach because of the concerns for occlusion of the internal carotid artery and the potential effects on CNS and cerebral perfusion. The modification performed by Dr. Abramson with his interventional neurosurgical radiologist Pierre Gobin was a direct cannulation of the ostium of the ophthalmic artery and a pulsed injection of chemotherapy over a 30-minute delivery period. This treatment can be repeated at 3 to 6 week intervals, and the initial study suggested an evaluation of a single treatment, but we've now migrated, as have others in advanced disease, to a selected focus on 3 primary repetitive treatments followed by evaluation. At the Bascom Palmer Eye Institute, we utilized this treatment approach as a first salvage therapy. We evaluated 12 eyes in 12 children that were scheduled for enucleation, and utilizing this treatment approach, we were able to eliminate the need to enucleate 9 of the 12 eyes. 75% of these children scheduled for enucleation after aggressive systemic and local chemotherapies were now spared the need for enucleation with this novel treatment. It was associated with significant tumor reduction, clearance of vitreous and subretinal seeding, and remarkable tumor improvement now documented on extended follow-up. As with any therapy, though, there was a unique set of complications that had not previously been seen. At the Bascom Palmer Eye Institute, we reported on these complications, including periocular inflammation and involvement of the rectus muscles, vitreous hemorrhage post-procedure, and apertures like retinopathy with hemorrhages in the retina and subretinal space. Rarely we saw neutropenia grade 3 or 4, but no child required support or unplanned hospitalization. So let's come back to our child, the 7-year-old Greek girl with unilateral, multifocal, advanced disease with vitreous seeding and exudative retinal detachment. As we discussed, her treatment may have included enucleation, followed by considerations of systemic chemotherapy, but in this child, this was our first child to treat with intra-arterial supraselective ophthalmic artery cannulation as a primary modality of treatment. She received Malphalon at a 7.5 milligram dose delivered over 30 minutes, and we applied large spot size laser. This is the intraoperative fluoroscopy showing the localization and placement of the catheter into the ophthalmic artery and allowed us to have primary drug delivery. This child had a classic response post-treatment with apertures like retinopathy. You'll see the tumor shows regression. There's focal hemorrhages over the retinal surface, and there appear to be deep changes at the retinal pigment epithelium. We applied supplemental laser to this child and showed progressive tumor response. And here in early 2009, we see the child back with 20/20 vision and excellent tumor control. This is presentation in April of 2009, the large tumor that we showed. Here she is now in November of 2011, now with stable disease, requiring no supplemental treatment, never receiving systemic chemotherapy, preserving this eye with 20/20 visual function. So in summary, this is a case of a 7-year-old Greek girl presenting with advanced retinoblastoma and a stage 5B ICR-CD classification, a late presentation with unilateral multifocal disease, and for us was the first application of supraselective intra-arterial Malphalon chemotherapy combined with focal tumor ablation, leading to an outstanding tumor control and 20/20 vision. Unfortunately, several questions still remain, and there are significant controversies with this therapy. The questions are, what is the right drug? What is the right dose of the drug? What is the appropriate number of treatment cycles? What should be the interval between treatment? And how do we understand this unique complication profile? Within the ocular oncology service here, we utilize tandem treatment, treating either the only involved eye or both eyes in a single treatment approach. We treat with a maximized dose, trying to deliver at a minimum 5 milligrams of melphalan to a maximum of 7.5 milligrams of melphalan. And we utilize a documented dose strategy that minimizes toxicity based on a body surface area algorithm to decrease the likelihood of systemic neutropenia. For moderate disease, we typically use a single treatment approach with the melphalan chemotherapy at 5 to 7.5 milligrams, and we combine this with local tumor ablation. In conclusion then, intra-ophthalmic artery infusion of melphalan chemotherapy appears to be a novel and uniquely effective tool in the management of advanced retinoblastoma, with significant decreases in treatment-related morbidity than seen with standard systemic chemotherapy. Huge advances in the management of this disease over the last 2 decades. So in conclusion, in 2012, retinoblastoma may be, in fact, the most uniquely curable malignancy. We've seen an evolution of therapy from enucleation to radiation to systemic chemotherapy to focal chemotherapy, culminating in intra-arterial delivery of chemotherapy to the ophthalmic artery. And we've discussed some of the potential novel strategies that may even eliminate the need for chemotherapy. The clinical pearls that you take home from this are that children that present without vitreous or subretinal seeding should have a 100% success rate in both eliminating their primary malignancy and preserving their globe, that children should have a 100% survival for intraocular malignancy in advanced centers, and that periocular carboplatin chemotherapy may be an effective strategy in supplementing local tumor control. This treatment has been limited by concerns of periocular complications, including fibrosis, and many institutions now have migrated to the use of periocular topotecan, which seems to have very similar efficacy without the associated treatment toxicity. Ultimately, intra-arterial chemotherapy may maximize tumor control while minimizing systemic treatment-related morbidity. The caveats to this are that this is a novel approach and that we are still only beginning to understand the potential unique complications associated with this delivery. Our future is to employ alternative strategies to improve local tumor control, to decrease tumor-related morbidity, and ultimately to move these strategies from the laboratory into early clinical practice, and then from early clinical practice into multi-centered clinical study review to document both safety, efficacy, and response. And what we'd like to eliminate is the need for this beautiful young girl who had her right eye enucleated is alive and well, to this young boy who presented, as we saw in his photograph, with vision compromised from macular retinoblastoma, but now has 20/50 vision in the right eye, 20/20 vision in the left eye, and has not required an eye to be removed. I'd like to thank my colleagues at the University of Miami and the Miller School of Medicine, and particularly thank Dr. Cristina Fernandez in our Hematology Oncology Department, and most importantly, Dr. Ali Sultan, who is our interventional neuroradiologist and has performed all of the intra-ophthalmic chemotherapy treatments over the last 2 years. My laboratory has been supported by the National Cancer Institute. Dr. Ted Lampidas is the world's authority on the use of 2-deoxy-D-glucose. And without the support and the integration of these collaborators and colleagues at the Bascom Palmer Eye Institute, we would not have the opportunity to bring this unique treatment approach to children with this blinding disease. Thank you for letting me talk with you today.